Hello, and welcome to our next in the series of webinars that the National Health Council has been holding on clinical outcome assessments, which we will refer to as COAs throughout this presentation. This month's presentation is about what do we mean by validation of a measure. Just to refresh your memory, National Health Council is a membership organization, and this slide depicts all of the patient advocacy group members of the National Health Council. An outline of what we're going to talk about today. We're going to talk about the objectives and have a brief review. We're going to discuss terminology when it comes to validation of measures. We'll have a question and answer session, and then for those of you who have time to stay with us a little bit longer, we're going to have a quiz, and we'll make a few announcements. The objective for today's session is to introduce to a patient group audience COA terminology and examples, and the learners at the end of this session will be able to actively participate in discussions about what validity is when we talk about the validity of measures, what makes a COA valid, and what the patient's role is in validity studies. A little bit of a refresher to start us off. Clinical outcome assessment, it measures a patient's symptoms, overall mental state, or the effects of a disease or condition on how the patient functions. COAs tell you something about how the patients feel and how the patients function. There are a variety of different COA tools. Most of us are familiar with patient-reported outcome measures, also referred to as PROs. PROs are reports that come directly from the patient about the status of their health condition, and that's without any amendment or interpretation by someone else, such as a clinician or a family member. Clinician-reported outcome measures are also called ClinROs. These are reports that come from a trained healthcare professional after they observe a patient's health condition. The third is called observer-reported outcome measures, and these are observations by someone else. It could be the caregiver, could be a parent, but it's someone other than a health professional. And lastly, we have performance outcome measures, also known as PERFOs. These are outcome measures that are administered by someone trained. It could be a health professional, or it could just be someone who's been trained to do the observation. And this is a trained person who absorbs a patient perform a task and then does a rating or scoring of how well they did that task. So these are the 4 clinical outcome assessment tools that are part of COAs. It's also important to understand the difference between a patient-centered outcome versus a patient-reported outcome. Patient-centered outcomes get at the outcomes patients report as what are important to them, the things that they view as being most important when it comes to their health condition. Patient-reported outcomes are outcomes reported only by the patient on how they feel or function. Keep in mind that we ask patients a lot of questions and ask them for information that they report on how they feel or function, and those are patient-reported outcomes. But they're not always patient-centered because we may be asking them questions about things that are not very important to them. So what we really want to strive for are patient-reported outcome measures that are also patient-centered. They are things that are reported by the patient about things that are important to them. So what do we mean when we say that we used a validated questionnaire? When we used a validated COA questionnaire. And we want to also talk about how is a questionnaire validated. And these are 2 things that we'll talk about today. Let's begin with some terms. We're going to talk about what validation means, and then we're also going to talk about the phrase fit-for-purpose measurement properties. When we say fit-for-purpose measurement properties, we usually are referring to content validity, construct validity, reliability, ability to detect change, and meaningful within patient change. Today we're going to walk through what these terms mean. Let's begin with validation. At the top, we have a very formal definition of validation. The process to establish that the performance of a test or a tool or an instrument is acceptable for its intended purpose. In other words, we're saying does the questionnaire do a good job of measuring what it says it measures among the people that are being asked to use it? Another way of saying this is the tool fit for purpose? Will it do a good job for the purpose that we have in mind? When we talk about fit-for-purpose measurement properties, we talk about content validity, construct validity, reliability, and the ability to detect change. That's what we mean when we say, is the tool fit for purpose? When we talk about these properties, these are the 4 most important properties, and we're going to talk about each one in a little more detail. Let's begin with what they mean. When we talk about content validity, what we mean is, does the instrument effectively measure the things that patients care about? When we talk about construct validity, we're talking about, does the tool measure what it says it's supposed to measure? Reliability means, what we mean is, does the instrument repeatedly reproduce the same score estimates? And then lastly, ability to detect change. Does the score change when it's administered, again, at a later time when we expect that there would be a change? Let's talk about each of these in a little bit more detail. In talking about the critical steps in the development of a fit-for-purpose or validated tool, we need to demonstrate that it measures the symptoms that are important to patients, the questions that are in it are relevant to that target patient population, and that they are easy to understand, that the instrument will repeatedly reproduce the same score estimates, that the tool measures what it says it measures, and that the score will change when we expect that there would be a change. This is what we're getting at when we talk about those measurement properties and that the tool is a fit-for-purpose tool. So let's begin with content validity. You'll see the formal definition above. And does the instrument effectively measure the things that patients care about? What we're looking for is, does this instrument reflect what is important to patients? And to accomplish that, we'll collect qualitative data from patients that's essential input into establishing that the content of that tool is valid and that it is a valid COA because it measures what is important to patients. So how do we establish that content validity? You'll see here some examples of the steps that someone might go through in order to establish content validity when they're developing a tool. The very top is where they begin the development process. They would look at the literature. What does the literature tell them about work that's been done in the past? They'll find existing instruments. They'll do instrument review of the questions that are already in those existing tools. They'll talk with experts like clinicians. And then they'll begin with the blue box that says concept elicitation. This is a formal process of talking to patients to ask them about what are the things that are most important to them when it comes to their disease and how do they feel and how do they function. They'll use that preliminary information from patients and from their searches, and they will begin to develop a tool where it says item generation and the drafting of the measure. And they'll create a draft tool. And then where the blue box says cognitive interviews round 1, they'll go back to a different group of patients and they'll ask them the questions that they've put together in that draft tool to be sure that that draft makes sense to patients. Did it measure the things we thought it was going to measure? We'll then proceed through the development process, and then we'll administer that draft tool to a larger number of patients. And that will lead to some instrument revisions once we learn from patients what they understood and what they didn't understand. You'll see in blue box that says cognitive interview round 2 with another group of patients. We'll do a second draft, and we'll ask those patients again, does it do a good job of measuring what's important to you and what we're trying to measure? And then we'll begin to finalize that tool and do some additional administration of again, larger groups of patients to do some more validation. And lastly, you'll see at the bottom of this page, we want to change this now from a paper version of that COA tool to now an electronic version of the Pro. if we do that change, we have to do another validation to ensure that the electronic version will work the same as the original paper version. So you can see this is all of the work that gets done to establish that it's still measuring the things that are most important to patients. Next, we're going to talk about construct validity. Again, the question is, does the tool measure what it says it measures? So for example, a group of patients have a particular disease, and it's expected to have the symptom of fatigue. When those patients complete the PRO tool, the scores should reflect higher levels of fatigue as compared to the scores of healthy people who complete that PRO tool. There should be a difference detected. So here's an example of establishing construct validity. Across the left-hand column, you'll see that the instrument that was being developed is called the factor, and the factor has subscales: negative emotions, positive emotions, uncertainty, and privacy concerns. Across the top of this table, you'll see 4 instruments. They were established tools that were already in use: the VR12 Mental, the GAD7, the PHQ-9, and the MHI-5. When we're trying to establish construct validity, we want to be sure that the tool does what we think it's going to do in measurement of the things that are important, and that it is zeroing in on those specific issues. So you see here, if you were to look across at the uncertainty row, you'll see that there are correlations that are listed here: 0.657, 0.679, 0.925, and 0.799. It tells us that uncertainty level is corresponding with uncertainty levels that have been measured in other instruments, and that there is a strong correlation there. That should be in line with what we expected it to do on that level of uncertainty, as opposed to other lines across for other subscales where the correlations are not as strong. Look at the bottom where it says privacy concerns: 0.268, 0.144, 0.220, 0.127. Those numbers are lower, indicating that there's a lower correlation there. We should have expected that lower correlation, and it should have been something that we thought we would see if we did this comparison. This is one way of establishing construct validity, and one of the kinds of tests that would be done. Next, we'll talk about reliability. Does the instrument repeatedly reproduce the same score estimates? There are different types of reliability. One is, does the instrument show a change when we would not expect to see one? So if that were to happen, it would not be reliable because we did not expect for a change to occur. So for example, patients had a higher fatigue score when their score was not expected to have changed. Again, a different kind of reliability is when 2 different interviewers are asking the same questions of patients in a short time frame. You would expect them to get the same response. So if patients prioritize the symptoms of fatigue in the same order, regardless of who was asking them the questions. To have good reliability, we want to have both of these be strong characteristics, that we would see the same responses when 2 different reviewers are asking the same person the same question and no change is expected, and that patients would have a higher score or a lower score as expected when their change was not expected to change over time. One of the important factors to consider is the time frame in between using these questionnaires or surveys. A change in time, or the length of time, for example, a longer period between when the questionnaire is first administered and when it's administered second, might change the reliability of that questionnaire. And so time factor is a very important element. Lastly, let's talk about ability to detect change. Does the score change when it's administered again at a later time when we expect there to be a change? So for example, patients completed the PRO at the baseline time period of the study, and then they completed it again 4 weeks later after they received a new treatment, and they experienced lower levels of change in their fatigue. we would expect that after treatment they would have lower levels of fatigue, and so that would indicate that the tool had an ability to detect change. Here's another example. At the beginning, at time point 1, patients say it was more difficult to go upstairs during the preceding 7 days. At time point 2, they say that it was easier to go upstairs in the preceding 7 days. And at time point 3, they say that that was maintained. It was just as easy as it was in time point 2 to go upstairs in the preceding 7 days as it was in the prior weeks. So the ability to detect change is important. We want to know, does a change in that performance outcome measure that we're using in this example, does that score during the follow-up visits correspond with other changes in mobility that patients report during those same visits? The patient's role is very important in the validation of an instrument. Patients are needed to participate in interviews, focus groups, and surveys, for example, in those concept elicitation interviews that we talked about earlier. And that's useful to identify what is important to patients. Patients need to complete questionnaires and answer questions about those questionnaires that they completed in those cognitive interviews. We want to know, were the questions and the response choices understandable? Were they clear? Do they get at what's important? So we need for the patients to be providing input into that. And patients would be needed to complete questionnaires at several times throughout the development of a new scale to ensure that responses are the same or different when they should be the same or when they should be different. It's important to remember that there's no such thing as a validated instrument for all uses. Every change in use impacts validation. If we go from a paper questionnaire to an electronic format, we have to ensure that it still has the same valid characteristics. When we change the timing or the procedures for use during a clinic visit, if we use it in a different setting, population, or condition from when it was originally validated, so for example, it might have been validated for use in one disease in a hospital setting, but now we're thinking about using it in a different disease in an outpatient setting. That requires more work. If we want to change the order of items, the wording of items, the wording of the response options, a change in the recall period, so for example, from the last week to the last month, or if we want to delete portions of the questionnaire, again, we have to ensure that it still has strong measurement characteristics. If we alter the instructions or where we place the instructions, and if we want to change it to be used in a different language or a different culture, again, additional validation work is needed. So in summary, we want to know, does the questionnaire do a good job of measuring what it says it measures among the people being asked to use it? Don't take for granted that a measure has been validated. Validation takes a lot of time and resources. Look for validation studies in specific populations and in specific contexts of use, how the questionnaire is used, to determine if the tool is validated for the way that you want to use it. You always have to ask, is it fit for purpose? Is it fit for the way you want to use it? Let's begin now with some questions.
Great. Thank you so much for that presentation. We've received a couple of questions through the chat function. The first question was, how does the validation that you're describing here apply to validation of something like a patient registry?
That's a great question because many of us that are familiar with registries, especially patient groups that have their own registries, have had to do a lot of validation work, and I think it's good to be conscious of the fact that the word validation can have a number of different uses. So when you're validating a registry, you're doing a lot of data collection, and you want to be sure that the data that you're collecting is being collected in valid ways. And so there is a validation process that goes on in any circumstance where you're doing data collection. That is slightly different than what we're talking about here, even though the two are very related. Here we're trying to validate the tool itself, the questionnaire itself. And so when you think about this, it means that there's levels of validation. are the questionnaires that we're using, whether it's in a registry or in other circumstances, are those questionnaires validated in the way that we've talked about today? And then the other level is if you're collecting data, and it could very well be that you're collecting data from one of these tools, are you collecting that data in a way that's been validated in terms of the data collection tool that you're using, whether it's a registry or a survey format or some other administrative or operational kind of tool that you're using to actually capture the data?
Great, thank you. The next question that we received was, I had not previously heard of performance outcome measures. Could you please elaborate a little bit and also provide an example of a performance outcome measure, please?
Sure. Performance outcome measures are one of the 4 clinical outcome assessments, and it's good to think of a performance outcome measure as any kind of a test or something that a patient might be asked to do. So, for example, people might be familiar with something like the 6-minute walk test, which is something that patients might be asked to do so that a clinician could observe them walking and how they perform that physical task. And it means that the person who's watching and observing the person perform the task that they've been asked to do has been trained to in some way score or rate that task and how well the person can do it. Sometimes it's a clinician, and then it's usually a clinician reporting on their observations, but sometimes it can be other people who have also been trained to make an observation of the performance of that task and give it a score. And so those are typically called performance outcome measures.
Thank you. One other question is, could you please explain inter-rater reliability once more?
Sure. Inter-rater reliability is very important, especially in circumstances where you might have an interviewer who is asking a patient questions. Anytime you have the patient, anytime there's someone who might be interpreting the patient's answers in some way, that could change the patient's responses. And so it's very important to make sure that interviewers are trained to ask questions in a specific way and to record answers in a specific way so that their opinions are not in any way interfering with what that patient's response would be. And they might be not. We don't want them to create a bias. We want to avoid bias introduced by having the interviewer's views put into the responses. And so it's really important to do training. One of the things that you need to do is be sure that if you have a set of interviewers, that they are all collecting the information the same way and recording the information the same way. So one of the ways of looking at inter-rater reliability is having several interviewers interview the same patients and collect the same data and compare the data that they've collected to ensure that it is the same, and where there are differences, try to figure out why there are differences to see if additional training might be needed or if something else is causing that to happen, because you would expect that if you have several interviewers talk to the same patient and ask them the same questions, they should be getting the same answers as closely as possible. That's inter-rater reliability.
Great, thank you. And finally, you spoke about the need to revalidate a measure when going from a paper format to an online format. Could you please provide a little more information about why we need to do this revalidation work?
Sure. Anytime you change the way that a patient is going to be reading or answering the questions, then it means that you have to revalidate. So, for example, the way that questions and the responses were laid out on a piece of paper, the ability for that person to circle an answer or make an X on an answer, those were the things that helped the patient to complete that questionnaire. And then as soon as you take that and you put it in an electronic format, you might change visually the way the questionnaire looked, the way the responses looked. You're asking the patient to answer the question in a different way. They might be asked to click a box or fill something out. Once you start to change the way that you've done that, and you've changed the circumstances, you may change it to something that the patient was able to understand when it was on paper, but is now not able to understand when you've changed the electronic format. And you want to ensure that the questionnaire is still capturing the information the same way that it was before on paper, and you might need to make some adjustments in order to be able to do that. So it's really important to go through the performance tests that we've talked about here, these measures that we've talked about, to ensure that the questionnaire still stands up the way that it did and has the same level of validity that it did when it was in the earlier format.
Great, thank you. That was the final question we received.
Great, so thank you very much. We're going to switch now and do a little quiz for those of you who are able to stay on the line. So you see here the familiar box that we used earlier with those measurement properties. We're going to give you a case scenario, and here's the reminder of what each of them are: content validity, construct validity, reliability, and ability to detect change. Researchers developed a new questionnaire for lung cancer. Patients stated that difficulty breathing is an important symptom. Patients were asked to fill out a draft version of the questionnaire, and they're asked to describe any confusion they had when they were filling out that questionnaire, that survey. Several patients reported that they weren't sure the questionnaire, what it was asking, when it was asking about frequency of a symptom or intensity. Based on this feedback, the researchers modified the wording in the questionnaire. So our question for you is, of those 4 measurement properties that we talked about today, what fit-for-purpose measurement property were they seeking to improve when they did this testing with patients to be sure that they understood the question and whether or not it was causing any confusion? Was it content validity, construct validity, reliability, or ability to detect change? The answer is content validity. Does the instrument effectively measure things that the patients care about? So patients reported that they had difficulty breathing, but when they were looking at the questionnaire wasn't making sense to them in terms of a wording of intensity and its relationship to the difficulty breathing. So the question had to be rephrased. Next question. The researchers compared the new questionnaire to an old questionnaire that has been used in the past in many past studies. That measure is known to measure shortness of breath very well. What fit-for-purpose measurement property were they zeroing in on when they were doing this test of the new questionnaire with the old questionnaire that they knew measured shortness of breath very well? Was it content validity, construct validity, reliability, or ability to detect change? It was construct validity. Does the tool measure what it says it measures? Are there any additional questions before we end the webinar today?
We didn't receive any additional questions.
Great. So we will go on to our announcements. The next webinar is going to be held on April 18th from 1 to 2 p.m. Eastern Time, and it's about measuring patient experiences, distinguishing between patient-reported outcomes and patient preferences. We're going to feature Pauline McNulty and Bennett Levitin. Hope you will join us. Please mark your calendar.